So it is May 22nd. Again, this is a recording for Friday. I apologize about being sick. I'm still not 100%, but I am present. So I have a 20-question ortho review for everybody. Oh, you have 2 questions? Yep, sure. Riley, go ahead. I'm sorry. Got some named Ann in the other cohort, so it's messing me up.
Okay, so just 2 questions. So for ortho, they went over muscle energy techniques. Is that the same thing as PNF?
Muscle energy technique is fancy PNF, yes.
Okay. And then symmetrical tonic labyrinthine reflex, is that the same as STNR?
Yes.
Okay.
Yep. And it goes with writing reflex, right? And all those reflexes, yeah.
That's it.
Yep, but you're in the right process. MET is just fancy PNF.
Okay.
It's what it is, you know, we had designed PNF and somebody had, you know, Cabot and Voss had kind of trademarked it, and somebody went, let's come up with a new version that's totally different from PNF, but it's still PNF, so we can trademark that and make money. Same idea. So yeah, they do it a lot in physical therapy. You'll find that out. They're like, somebody comes up with an idea and then somebody else changes it slightly and comes up with a totally new idea. Did either of the other 2 have any questions? Are you doing okay other than that?
I'm okay right now. I don't really have no brain questions just yet.
No brain questions. Got it.
No.
I got a little confused with the convex and concave.
Okay.
But I think I got it. So I just wanted to go over like, so I know convex is roll and glide in opposite directions. And then concave in the same direction, right?
Let me bring up, just so I have pictures up. Hold on one second.
Okay.
That makes things easier.
Helps.
Yep, that's, I have pictures somewhere. I just have to figure out where they're at. Because this is always one that comes up, so it's not something. And then I also had somebody request going over hand injuries. There's convex concave. Remind me later. I don't need to restart right now. All right, so let me bring this up real quick. I'm also going to post these 3 YouTube videos because I really like these 3 YouTube videos. So let me post those into the chat for you. There are 3 really good YouTube videos I found on convex and concave. Save those. Let's get in here. I'm going to maximize my PowerPoint. Where did my PowerPoint maximize at? That's weird. Oh, it maximized on my baby window. That doesn't help.
Struggling in discrete math.
What was that?
Understanding your.
Oh, was my video?
Oh, okay. I was like, wait, what?
Sorry.
That's okay. I was like, wait, what? Hold on a second. It is, if you want the funniness there, when you have multiple screens, I have a little screen on my computer that monitors my temp, and my PowerPoint was broadcasting on that. I was like, where did my PowerPoint go? Oh, it's fantastic. There it goes. Which one goes? Why is it broadcasting over there? Oh, there it is. I need to exit out. I see what I did wrong here. I don't want automatic. I want to use my primary monitor. There we go. Fixed it. Like literally, I have a 4-inch screen on the side of my case, and that's where the PowerPoint. That's not going to be very good for you guys. 4 inches. All right, share screen. All right. So with convex and concave, right? The 2 main things of pre-convex concave you have to get is the osteokinematic and arthrokinematic. Are you okay on those? That you understand the difference?
With like the rule for convex and concave?
Well, even before we get to the rule yet, just that you understand the difference between an osteokinematic motion and an arthrokinematic motion, in case they ask that question on it. So osteokinematic is the bone movement at the joint. That's the goniometry. Right? That's what we do, you know, when we're measuring elbow flexion or we're doing passive range of motion, active range of motion, we're doing the osteokinematic portion of it. Does that make sense?
Okay.
And then the arthrokinematic is the joint surface motion itself. That's when we get into the rule of roll, spin, and glide.
Okay.
Right? So when you have a question on the boards, if it's asking you about osteokinematics, you've got to go back to range of motion. If it's asking you about arthrokinematics, that's when you're thinking joint mobilizations and going on the roll, spin, glide idea. Does that make sense? Kind of.
Yeah, I think so.
Okay.
Don't
So-
remember this, but
That's okay. That's why I wanted to read. This is kind of a basic. When I had a stroke. When you have board questions, a lot of times they'll mention stuff. They'll be talking about osteokinematics, and the main problem with that is students, as soon as they see kinematic movement, for some reason, automatically go right to joint mobilizations. Because it's just, that's where your brain goes. So somewhere in those questions, they'll be talking about joint mobilizations.
okay.
But if it says osteokinematic, it's not joint mobs, it's just your normal range of motion type activities. So goniometry, active, passive, active assist, all those type functional range motions. You know, so if the question was talking about a patient having a limitation with their osteokinematics, what would be the most appropriate treatment for them? It would be one of the range of motions. Does that make sense?
Okay. Yeah.
Versus if they're having a problem with the arthrokinematics of the joint, that's when we talk about joint play and joint moves.
Oh, okay.
Does that help clarify that at least a little bit?
Yeah, I didn't.
Okay.
I
We talked about this, but that's okay. It's
Yeah.
a long time ago and land far, far away.
okay. I think those words always confuse me too because they're so close, and it's like,
Right. And that's the thing is that's an easy way for the boards to kind of get you caught up.
oh, definitely. Okay.
Right. So the main thing is what the way I always remembered it is osteo has an O in it. All my range of motions have an O in it.
Mm,
Active, passive, right? So that's the way I always remember, like osteo, OM, osteokinematic motion, P ROM, A ROM, AA ROM, AA RON. Oh wait, no, that's a different subject. Does that make sense? That was my head. That's where my head went with it. And then I thought arthro, joint moves.
it makes sense.
Okay, cool.
Okay.
Then we got our general arthrokinematic motions. We have roll, which is the rotational component, right? We have slide and glide, which is a shear. That's where it kind of slides back and forth. And then we have spin, which versus roll, which is like this. Spin is like the screw home mechanism on the knee, right? That's where it kind of locks stuff in place.
I had a question about that too. This
Okay.
mechanism.
Okay, let me write that down. We'll come back to that, but I just don't want to forget about it. So we'll come back to screw home. All right, so when we're talking joint mobs, right, the first thing you have to determine is what is moving on what, right? That's, if you remember nothing else about my stuff from way back when, that was the main thing I talked about is you have to go, okay, you know, do I have, if I have two surfaces, there's my two bones, right? I have to figure out which part of the bone is moving. So the first thing you have to do if you get a question is talking about the roll, spin, glide rule or convex concave rule is go, okay, am I open kinetic chain? Am I closed kinetic chain? Which bones are moving? So that's where you literally, when I had these questions, I drew them out. I drew a little bone, and then drew arrows for which one's moving. And that helped me determine which was my convex and which was my concave. Does that help a little bit on that at least?
Yeah, that helps. I just like when he was going over the review for like the fingers, I got confused when like, so when you're flexing your fingers, that it's rolling and gliding in the volar direction.
Okay.
And like, I don't know why, like, I can't see that. Is it just because it's like,
Stop using volar. That's probably the first thing you can do. So what's the other term for volar?
Anterior?
Okay, so we have what are the two motions we have at the finger? We have volar and we have
Palmer.
palmar, right? Palmar is forward all the time.
Forward.
Think about the Vitruvian man position is here.
Mm.
So that means palmar is always anterior, volar is always what? Posterior, or the other term for volar would be dorsal or posterior. Yes, there we go. Thank you, Riley. Good, right? So that's one of the first things when I get a question, whenever I get palmar or volar, the first thing I do is translate it because otherwise I'm screwed up. Because all that is that's a fancy way of messing you up. That's it. That's all it is. I'm just saying that right off the bat. So we've got our finger. Let me see if I can get a picture of a finger really quick. Just so that we have, oops, I gotta clear my drawings and get out my drawings, or it's not gonna let me do it. Drawings of the fingers. Just so I can get a good picture of a finger up here. That's a really tiny picture. There we go. It's actually, it's not as good as I want. That one's actually pretty good. Let me switch my share screen real quick. All right, so can you see the fingers? Yeah, okay. So when you're looking at the fingers, remember that as it goes, it always goes pointing out, suction cup, pointing out, suction cup, pointing out, suction cup. So we've always got the vex, cave, vex, cave, and then you got here, it gets really screwed, but it's still cave. Right, so as I'm flexing my finger, it depends upon, I can't really do a flexion closed kinetic chain, it doesn't work out, right? So they're all gonna be open kinetic chain, right? So I'm flexing, so that means which bone is moving? The cave or the vex? The cave, the cave, because it's the one out here. So if I, and think about it, just isolate one joint. So I'm going to isolate just the PIP here, right? So my vex is pointed outward, my cave is gliding. So that means we're using the concave surface on a convex surface. If I keep rolling this way, right? So that goes back to our rule then. Our rule, if you remember way back when, the rule is if you have a convex surface, it moves in the opposite because things that are vex are opposite to you, right? Vex make you, if I vex you, I make you mad. I'm being contrarian to you. I'm opposite of you. Versus we want to put one direction in a cave. Right? So concave rule is all in the same direction. I know it's silly, but you're going to be sitting at the board. So you're going to get a question on this. You're like, oh yeah, we put one direction in a cave. And that's going to help you remember it. Right? So that means if I go back to my picture here, because I just closed it real quick. If I am rolling, if I'm moving anteriorly, because that's the way I'm going here, right? That means I'm going to glide posteriorly, so I don't roll off the end of my finger. So otherwise, if I just keep moving, if I just was to keep moving and not have any glide, this finger would fall off. And I'd end up with that bone being broken. It has to glide a little bit posteriorly in order to stay attached. And I think the problem you're getting is the volar versus palmar probably is messing you up.
Yeah. I'm like, because I'm like trying to see it and it like confused me. So, okay, when you're flexing the finger, it is concave moving on convex.
Yeah.
And
oh, I just messed that up, didn't I? I did just mess. No, I didn't. No, I didn't. Never mind. I said it right. My brain is, thank you, Riley. I was just like, wait, I just totally thought I messed it up there for a second. Yes.
And then, so it's moving in. The same, no.
No, I did mess it up. No, yes, because my concave surface is moving on my convex surface.
Isn't that what you said? The concave is moving on the convex?
Oh, I did, yeah. Okay, I'm just messing my own brain up at this point. Sorry, I'm sick, guys. I apologize. Right? So everything has to go in the one direction, right? Concave on convex. So as it glides, it rolls in the same. Because think about it, if it didn't roll that way, it would just kind of flop off. So I've got a saddle joint there, right? Now, I'm going to give you a really peace of mind here, Brooke. They're not going to ask you about the fingers.
No, okay.
So
That
don't,
was my question. Like, do you think it's more for like the shoulder, hip?
it's going to be
Right.
shoulder, hip, elbow, knee.
Shoulder, hip, elbow, knee. Okay.
Yes.
You were going with
Maybe
shoulder.
an ankle. But for the most part, shoulder, hip, ankle, shoulder, hip, knee, elbow. Right? Because those are our major joints. It's very unlikely you're to get a finger joint. I mean, that would be like the 1 in 1 million question, because fingers and hands are a specialty. Right?
Oh, I'm like spending time on it.
I know.
So for the shoulder, let me see, because I just went, Brooke, don't worry, because I literally had the same thing with Riley like 2 days ago.
Oh my
So
God.
for the shoulder, let me just repeat it. Let me see if I have it. For the shoulder, the convex would be the humerus,
Mhm.
and the glenoid fossa would be the concave.
Yep.
So that convex is moving opposite.
Yeah, almost all the time. So almost all the time for most of your
Got it,
shoulder
Riley.
motions, almost all of your shoulder motions are going to be open kinetic chain, right? Almost all of
Right.
them.
Okay.
When
I
would
only have the shoulder down. That's
yeah,
it.
when that's okay. Let's kind of go down through this. I'm going to actually get out of the screen here just so that you can see my whole body.
Yeah, get rid of the fingers.
I'm getting there. I'm getting there.
I've like
Right.
spent so much time. on
Okay. I know. Don't worry. Again,
it.
if you get the fingers, just draw them, but you're not probably going to get it. Let's start with the shoulder, right? Shoulder, we have humeral head,
Mhm.
glenoid fossa. So most of our motions of our shoulder are going to be open kinetic chain, which means it's a vex on a cave surface, right?
Yes.
Because think about all of our, what's the only way I can really do a closed kinetic chain?
Like a push-up,
A push up or one other one? What other up?
a pull-up.
Pull up or a lat pull down if there's a bar, right? Yeah. Handstand, I guess, too. I didn't think about that one, right? But they're not going to ask that question on that. If there's going to be a closed kinetic chain, it's probably going to be a push up, right? Or a wall, it'll be a wall push up or a regular push up. That's the only time that would reverse,
Yes.
right? But for the most part, it'll say your patient, you're performing shoulder flexion, right? So shoulder flexion in the air is going to be a open kinetic chain, which means that the humeral head is moving on the concave surface of the glenoid fossa,
Mhm.
right? So that means if it is rolling, because that's going to roll anteriorly, correct?
See, that's where it gets me.
Why?
Like, I feel like it's rolling like back, like posteriorly.
Trying to think of an easy way to.
Like-
Maybe try to picture the humerus on the
Yeah.
glenoid fossa. That's what helped. That's how Riley explained to me. And if you just take 1 second to think of how the humerus looks on the glenoid fossa, maybe that helps you.
Yeah, and when you think about it, it's more about which way the whole bone is going, not necessarily just the head itself. Does that help you a little bit? Because think about it. So if I'm here, right? If my whole humerus is moving posteriorly, it's going this way. It's going into extension.
Mhm.
So that means this has to be moving anteriorly.
So don't just think of like the head.
No, the head is just for the what do you call it? The actual rule.
Okay.
Does that help a little bit?
I think so, because I was actually thinking of what the head looks like. Like, say if we are going an extension, I'm thinking the head is rolling like forward. And so it would be like anteriorly, but I guess it's in the motion that you're going.
In the
Okay.
motion that you're going, right? Yes.
I'm making it way difficult.
Yep. That's okay. That's why it's good to kind of go over it. That's okay.
Yeah.
Right?
Yep.
So most of your questions are going to be whatever direction it's going, because it is a vex on a cave. That means that the slide and glide is going to be what? It's a vex surface, so that means it is opposite. Good. Yeah. Otherwise, think about the humeral head in there. If it doesn't do something like that, it's going to like and fall out of the socket. And we definitely don't want that.
Okay.
Does that help a little bit?
Yeah.
Okay.
I have it backwards.
That's okay. Let's go down to the elbow really quick. Just let's go through the four main joints. The elbow is, which is my convex surface?
Would it be the olecranon or no?
So think about here's my humerus,
Way off.
my trochlea, right? My trochlea is my main thing it's rotating around. And then I have the trochlear notch grabbing onto it.
So like the ulna is the convex, right?
Other way around. The trochlea is up on my humerus. So the trochlea is my round part, right? So that would be my convex surface. My chomper, my good old trochlear notch on the ulna is what is my concave surface. Do I need to bring up a picture so you can see that, or?
At the humerus right now. Okay. Yeah.
Can you explain it one more time, Mr. Mikiva? I'll pull the picture up just so
That's
I
okay.
understand.
So your vex surface on your elbow is your trochlea, right? The spool of thread. And then the cave surface is the trochlear notch that's sucking into that spool of thread. It's often confusing because you think of the olecranon and the olecranon fossa and like, oh, but that's not what's holding that whole joint together. All that does is locks it, right? That locks it into extension. That's kind of the screw home mechanism of the elbow, right? What's actually moving is the part going like this.
So the convex surface is the
humerus. Is the humerus.
Okay.
Right? The convex surface is the humerus. The concave surface would be the ulna.
Okay.
Right? What about the radius? Does it have anything to do with this at all?
Just articulate.
No. Yeah, it's just articulating it, right? That the radial has just to allow pronation supination. So just completely ignore the radius. I threw that in there on purpose because they may be talking about the arthrokinematics at joint and say something about the radius, and then all of a sudden you're sitting there going, that's just there to make you angry. That's all that's there for, right? So vex, humerus, ulna, cave, boom. And for most of that, again, most of your motions there are going to be pretty much open kinetic chain again, unless of course you're maybe doing a push up again or a pull up again.
So elbow flexion is,
for the most part, open kinetic chain, right? So that means it's a cave surface, the ulna, moving on the vex surface, the humerus. I see you absorbing it. It's okay. Take your time.
okay. So
Here's my Pac-Man eating my humerus.
concave moving on convex.
Concave moving on convex. Yes. So that means just like one direction, we put them in the cave. So they all move in the same direction.
And so this would be anteriorly,
Okay. Yep. Be rolling anteriorly, which means it would glide.
posteriorly.
Same direction. Cave.
Okay.
We put one direction. Just keep thinking. One direction goes in the cave because they suck that bad. One direction goes in the cave because they suck that bad.
I'm gonna have to write that down on the test to remember.
That's okay. There's nothing that says what's your limit on. Just don't spend all day writing stuff down because that could slow you up, right?
Yes.
Aren't my baby cans so cute? Aw, it's like one swallow. So yes, okay. So then we move down to the hip, right? What is my vex surface of the hip?
Greater trochanter.
What on, you're wrong side.
The femur?
Yeah, the femur. The femur is my
Right.
vex surface, right? The femoral head.
Mhm.
And then
It's just
so
like
your
the shoulder,
so
right?
the concave would be the acetabulum.
Acetabulum. Good. Right?
Mhm.
Now the legs are where you get a lot of closed chain questions, because what are they going to ask you about? Doing what exercise?
Like squat.
Standing up or squat. Okay, gate's another one too, right? Anything where the leg is attached to the floor,
Okay.
right? Pretty much the only time I can do open kinetic chain is when I'm doing something like this, right? Most of my stuff I do at my leg is closed kinetic chain. So we got that, and then let's go down one more. Let's go down to the knee, right?
So closed kinetic chain, meaning that the acetabulum concave is moving on the convex.
There you go.
Okay.
Yes, good. You got it. And that means that the only time it's pretty much opposite of the shoulder, right? The shoulder pretty much are all open kinetic chain.
Mm.
At the hip, it's a lot of closed kinetic chain. And that makes sense because that's our weight bearing joint. And let's go down to the knee. Last major joint at the knee, which is my vex surface again. The condyles, good. The condyles of the femur, right? Good. Okay, I see it clicking. And that means that the tibial plateau is my cave surface, right? Or condylar plateau is what it's typically called as well, which makes sense. If you have condyles, you got to have a plateau for those condyles. Does that help a little bit? Are we okay on most of those? And again, then it's just asking whether it's talking about doing like a long arc quad versus standing up. It's pretty much, or in gait. Like certain, and you remember when you're on gait, make sure you're thinking about what it's asking about. Because if it's in swing phase, is it open or closed kinetic chain? Open, yeah. Right? If it's in stance phase, almost all of it's closed kinetic chain. Does that help
Thanks
a little
for that
bit?
review.
What's that?
Yeah.
That help
I
a
said
little
thanks
bit?
for that review. Yeah.
Yeah. And then it's just analyzing what the question is asking you. Is it telling you this is moving on that or that is moving on this? And that's where you either got to do the motion, which I did a lot. I was in my little cubicle. I'm like, doing PNF, right? I'm hiding in my cube because I remember that I was sitting out way like this doing all kinds of gait stuff. And the lady comes in, she's like, "Sir, you have to sit in your cubicle. You're disrupting other people." And I'm like, fine. And I slid in and I'm like in there making these little itsy bitsy movements. Because I have to visualize it to get it to work. And so, you know, I was making giant, I remember the one she caught me on, I was out there doing D2. And I'm like flailing my arms all around. Yeah, disturbing the other people. So just don't be me that way. Slide in your cubicle when you do it. Does that help with that though? Okay, good. Yeah. And honestly, those 3 videos I sent are really good. I think one of them is even like those animation drawing ones where it like draws it for you and it kind of that helped a bunch of the students. So take a peek at those. They'll probably help you more than you think. There we go. Yeah. Are we good on all that then? You want to try the review or you got something else? Oh no, Brooke, you said screw home.
Oh, yes. So when I was watching the video, I feel like I heard him say something about the femur and then something about the tibia, but I think I got it down. So it's the last 10 to 15 degrees of going into extension. The tibia externally rotates on the femur to lock it in.
Yes, I think about that. I think about it from the other direction. I think about
Think about it from either or.
Yeah.
Oh,
Mhm.
okay. So
I think about it more from the femoral area, but either way works.
So the femur would be internally rotating.
Yes. Yeah, because you got to think about it. You got to sink into that socket.
Yeah, it like locks it.
It locks it in.
Ask either or.
Yeah.
About that.
Yep. Either one of those is fine. I typically think of it from the femoral direction because the femur is my big bone, so that helps me that way. So if I think of it if I think one goes one way, the other goes the other. It's just kind of the way it is.
Okay.
And then with the screw home, what direction does or should your patella go? Which direction should it slide? Should it slide medial or lateral?
Lateral?
Medial?
Medial. Because remember, when women have PFPS, the problem is the patella tracks laterally because of that Q angle of the hip.
Oh, yeah.
Right. And so we tape the knee a little bit medially in order to help with it.
Okay.
Yeah. Does that help a little bit? So it just kind of slides medially. It doesn't,
very slight.
Very slight, but enough that it locks into that spot between it. And the main idea is if it didn't, you've got that big tibial crest down there and it's going to pop the patella right off, kind of.
Yeah. I think you can actually feel it too. When you,
yeah.
Okay.
Right.
Yeah.
And ironically enough, I don't know if you guys saw, but the idiot white supremacist Tim Pool had a whole thing about that with the Q angle of females' hips. And that's why men shouldn't be, men that identify as women shouldn't be in women's sports because the Q angle makes them a better athlete. Yeah, it was like, he had no idea what he was talking about, the whole Q angle. And I just read that tweet going, oh, this is why people that aren't in science shouldn't talk about science. It was great. He said that's why females can't jump. Most females can't jump more than a few inches. Have you seen the WNBA players? I'm just saying. Anyway, does that help with screw home though?
Yeah.
Okay. All right. That's the only other thing, and I'm just gonna go over that because I had somebody that requested this real quick. Let me bring up the.
I have another thing too.
Sure, go ahead. That's why we're here.
It's about like I think it's like no, I don't know if it's a forefoot. I think it's rear foot valgus and varus.
Okay.
So I know it's just the rear foot that is like taking hold of the varus or valgus. It's not your forefoot.
Mm-hmm.
And so when it's in varum, I just got confused because they said it's like internally rotated.
The foot internally rotates a little bit. So the foot will kind of roll internally. So remember, when we talk about or we talk about valgus and varum, right? It starts all the way up at the hip.
Yeah.
And then it goes the whole way down, right? So you have the hip, then the knee is opposite of the hip typically.
Yes.
Right? And then the ankle is typically matching the knee.
Oh. Okay.
So if I have coxa vera of the hip, I'll have genu valga, and then God, I can't remember what the one is. This is the term for the ankle at this point, but yeah, I'll get the ankle as well.
Okay.
Why did I just draw a blank on that one? Anyway, the ankle valgus. So, right, and it just depends upon the way I always remembered is it's kind of the direction of the calcaneus pointing. That was the way I always kind of remembered it.
So if it's pointing, like
if it's pointing, so valgus or varus would be a wide ankle,
wide,
right?
Like bow-legged.
Right, it'd be like bow-legged. Good. If that's pointed, so if my calcaneus is pointed like this, my foot's going to roll inward because all my weight's going to collapse in on the inside of my foot because I've got the outside kind of rolled up.
That's not valgus?
What? Think varus, very wide ankles. You just said it a little bit ago. When it's varus, it's rolled in. You literally just said this.
I can't picture it. Like, okay, so I'm trying to look at my foot. So almost like if it's supinated, right? That would be
That would be valgus.
That doesn't make sense.
Okay. Here's my calcaneus, straight up and down. My weight's going to be buried evenly across the whole bottom of my foot. Does that make sense? Because as I plant down, I'm going to be able to roll through nice and smoothly because I'm driving all the weight down on the center of my calcaneus. If I go into varus, now my calcaneus are pointed kind of outward. Right? Varus is very wide ankles. That's why I always remember it.
Okay, so that's where I get caught up because I think if my ankle is pointed outward, which would be internally rotated, that my knees are going to be knock knee. But if it's the same at the knee,
same as the knee of the ankle,
then I don't need to think that way.
Nope.
Just know that when it's varus, my ankle is shifted out, which means it's internally rotated.
Yes, the foot would be internally rotated. Yes, you don't. It's more of when you talk about internally rotated, you're talking more about the rotation of the foot itself. So supination versus pronation. But yes, you've got it right. Yes, stay with that. Stay with that brain thought.
Okay.
I don't want to get because I think if I go any further, it's going to mess you up a little bit in the brain. Just stay with that brain thought. Yes, stick with that brain thought.
Supination helps me too because it would be in supinated, right?
Yeah. Mm-hmm. You got it.
Okay.
You're doing okay.
All right.
Breathe.
Okay.
All right. So one thing that I had a request for somebody that's not here, but they did want me to kind of go over it, were the general diseases of the hand. Because they said they started looking at that and started freaking out. So let me bring up my little memory jogger of the hand. I know they're not here, but I still want to at least. Do you remember all of these diseases of the hand? All this fun stuff from anatomy? Oh, I see Riley's face. Right? The main questions when you get about this are understanding kind of what's affected and what part of the hand is affected. Are you going to get a ton of these questions? Probably not. You might get one or two of them. And the main ones you're going to get are foosh, right? Fallen outstretched hands is going to be the big one. And then what do you think the other main ones you might get are?
Carpal tunnel.
Carpal tunnel, good.
Colles fracture, maybe?
Colles fracture, right? And it's maybe Smith's or reverse Colles, right? So just going down them really quick. Carpal tunnel, what you need to get in your head is as soon as you see carpal tunnel, think of median nerve, right? Those first three fingers, right? And the big question they ask a lot, and I can demonstrate it really easy if you look at my hands. So I don't know if I can angle it right. So carpal tunnel, do you see how I almost have no muscles in here in my thenar eminence? Then compare that to this hand, right? This is my hand that has nerve damage. Even my hypothenar eminence is gone. I mean, that is actually gone compared to this hand, right? So carpal tunnel, median nerve, thenar or thumb side hill, right? Thenar eminence, that wastes away. Yes, right? The opposite of that is ulnar damage, right? That would be the last two fingers and then the hypothenar eminence. Dequer veins, what the two things I remember about dequer veins, if I encounter it, is that it's also called mommy's thumb, right? It's from baby screwing up mommy's finger. The other thing is we are getting it right now from, right, texting. It's inflammation of the extensor pollicis brevis and the abductor pollicis longus, right? So do you remember the test for that? There you go. Yep. What's that called?
I just remember you say you did that because you play your game too much. And
Yep. Yeah, if I do it with the right hand, I can't feel it on this hand at all. But if I do it with this hand, I can, yeah, instantly. That's the funny name test.
Funny what?
It's the funny name test.
It's called the funny name test?
Well, no, it's got the funny name. It's not the Frankenstein, it's the Finkelsteins.
Finkelstein, okay.
Yeah. So that's the main, when you get a question about that, it's probably going to ask you what test for it. And it's the Finkelstein's test. So that's pretty much dequer veins. And then we have Colles and Smiths. And just remember that Colles and Smiths are the reverse of each other. Right? So Colles, and then is the posterior fracture of the radius. So that's where the radius goes backwards. Usually that follows with the Fuchs fall. As I fall, the scaphoid gets driven back and my bone pops backwards. So typically if I fall on outstretched hands, I'm going to end up with a scaphoid and a Colles fracture. Right? Because the scaphoid sits kind of right here. It's going to pop that backwards. And then you have the reverse Colles or the Smiths. That's where the radius goes forwards. And
How does that happen?
I mean, a lot of times I've seen it happen from people that like bang their arms off stuff and stuff like that. Martial arts is a lot like MMA and stuff like that, where they get people in locks. That's the main place I've seen it. Like, especially people that do like jujitsu and Krav Maga, where they put the wrist, because the primary lock you do on a wrist in those is like this. And that's an easy way to torque that radius forward.
And the radius would, wait.
So radius would go out the front of the arm, anteriorly displace. Right? So posteriorly, Colles, anteriorly, reverse Colles or Smiths. And I think that's why it's called a Smiths, because it's from banging on like a blacksmith type idea, banging with the hammer, I think is where it comes from. I don't quote me on that, but that's what I understand. And then we have boxers. Do you remember how boxers happens? So it's not in here. No, that actually is a good punch. They miss in here and they hit out here. Right? That's where they swing and they miss and they catch that pinky. So it's a fracture of the fifth MCP. And I already mentioned scaphoid or the Fuchs, right? I always love this joke. The Fuchs goes hand in hand with the Colles fracture. Get it? Hand in hand. I'm so funny. You guys missed that. I know you did. And then we get down into the deformities. And the deformities are ones that tend to screw people up. I'm going to try to give you my easiest way of remembering this. Dupuytren's is where you have a contracture, usually of the fourth and the fifth digits, but it can be any digit, but it's typically fourth and fifth, where it's the actual tissue itself contracts up. It's usually congenital. So if you've got a family member that has Dupuytren's, it's very likely you're going to have Dupuytren's as well. Dr. Vreskin has Dupuytren's of her third or fourth. Because you can see it when she was, if you ever watch when she's teaching, that ring finger doesn't extend completely because she has a small Dupuytren's contraction. And as far as Dupuytren's contracture, the only thing we can do at that point is lengthen it. Yeah, right. It's going to look a lot like claw hand deformity, right? Because claw hand deformity is going to be out here as well. But claw hand deformity is nerve damage versus Dupuytren's, which is soft tissue contracture. So are the treatments going to be different for nerve damage versus tissue contracture?
I would think so.
Yeah, right. For tissue contracture, we're going to try to heat it up and stretch it. Right. For nerve damage, well, it depends upon where the nerve is damaged at, if it can even help it. Right. So Dupuytren's and typically claw hand go together. The only reason is Dupuytren's is the soft tissue contracture. Claw hand is because my nerve is no longer able to extend those fingers. It's the same appearance, just different methods of it happening. Does that make sense? They look alike, but you have to determine, is it nerve or is it soft tissue? I really should have brought my wife in to talk about these, but she's going to yell at me and tell me I got something wrong. I know when she watches this video, she always does. And then Benediction hand goes along with carpal tunnel syndrome. What does Benediction hand look like? You know what benediction is? May the Lord bless you and keep you. May he make his countenance to shine down upon you and give you peace. right? Whereas carpal tunnel is median nerve damage. Typically, benediction is median nerve paralysis. So the hand kind of freezes down like this, right? They can't fully extend it. So the fourth and the fifth fingers are able to move, but the third and second are stuck. So they kind of get stuck here. And I have pictures of them coming up. So let me see if do I have pictures in the next slide here. Yeah. So top corner up here. Oh, I see a chat. Sorry. It's Sunday. Exactly. So top picture up here, that is your typical presentation. So carpal tunnel, these three, ulnar issue, these two, right? There's the picture of decurvanes. Oh, there's a nice picture of Colles, actually. I didn't realize to put that in there. So Colles, that bone goes backwards. That would be kind of painful, right? And then a reverse Colles, that radius would go that way. We'll get to mallet in a second.
I have a
There's,
question about the Colles and Smiths real quick.
yep, well, I'm good.
So wait, so this is covering this. You said that's a Colles right here.
Yes, that's a Colles in the picture, yes.
So it's gonna be like this, the radius here is coming out here.
It's going backwards. See how this, so here's my palm, it's going towards the back of my hand. The radial end is snapped out. There's a silate process and everything. The radius is going that way.
Out the side?
Well, it's more going backwards than it is outside. I mean, it'll break off and go out the side a little bit, but it's more about whether it goes anteriorly or posteriorly, the fracture. So in that case, the radius kind of is going to shift forward, but the break is going backwards.
So this one goes posteriorly?
Colles goes posteriorly, yes. And then a reverse Colles would go anteriorly. So when you see Smiths, just automatically say reverse Colles, because that means it goes anterior versus posterior fracture.
Here I am getting confused again about like the positions.
Remember, always go back to what? Anatomical.
Phase. But okay, so this is like anterior, right?
Yep, anterior surface.
That's why I'm like, when I look at
Don't think about the bone, think about the radial end.
Oh,
there you go. What's that?
wait.
Think about the part that is breaking off. The part that is breaking off is this little chunky here, right? So that little chunky in a Colles is going to go to the back side of the arm.
Okay. Yeah. Okay.
Right. So you're basically your styloid process and all the stuff that's attached to it is going to go this way.
And then the rest is coming here.
Yeah. Yeah. It's going to push a little bit forward. Yeah. But the main thing is the chunky snap is going backwards.
Okay.
And then a reverse Colles, the chunky snap goes forwards.
Wait, it goes this way.
Yeah. Palmer direction.
This way.
Okay. Right.
I'm sorry.
That's okay. No, it's
like,
fine. I'm trying to get myself right. There we go. Colles, my break goes that way. Reverse Colles, my break goes towards my palm, anterior.
Okay.
Remember, for Colles, most times it's because I fall like this. And the only way the bone can go at that point is backwards.
Okay.
Does that help?
Yeah.
It's
Okay.
because if it snaps forward, I did something really impressive with my wrists. I'm just saying. I felt like this.
Oh my gosh.
Mr. McKeever, I have a question.
Uh-huh.
So do you think I can narrow down on the special test, or do I absolutely have to memorize all of these tests?
You know, you can probably narrow down. I think I might have a slide on that, on the ones that are important. Let me look real quick then. But you can narrow it down.
Because that's what I'm trying to do for like
Yep.
all the joints, because they have a lot, and I just feel like I know I'm not gonna get tested on all of these, so I just feel like I don't want to waste my time
That's
on
okay.
the stuff that
Let's get through this and then I'll cover that. So save that for a second.
Perfect. Thank you so much.
Yeah, I'm just gonna write it down so I don't forget about you. So I keep my little tablet here. So actually, now that I see Brooke, I didn't even notice I had this down here. Guess what? There's my reverse Colles fracture. This is my Colles, there's my reverse Colles. The bone is going towards the palm. It's the front anterior surface of the radius is snapping versus the posterior surface. I've lost you, I know. It's okay. You'll get it. Just think about it a little bit. It's okay. These things happen. APAN goes along with Benediction Hand. They're not going to ask you about that. I put that on there. But for the most part, I'll be honest, although we have APAN, we have Benediction Hand, we have all this, it's really going to be carpal tunnel. I put this on here because people freak out all the time. The only other ones, I'm going to be honest, that you're going to get questions on are boutonnieres and swan necks, right? So a boutonniere's deformity, and I was told to make sure I put this down here. It is a central extensor hood rupture. Whatever, that's going to mess me up. The central hood rupture where you end up with MCP extension. So your knuckle extends, right? And then your PIP and your DIP flex. So your finger ends up like that. Because it's an extensor hood rupture, your fingers pull into flexion. That is a boutonniere. So if you see people that have start where their hands, my fingers don't completely contract or extend. I can't, it's really hard for me to get fully extended. I have what's called pseudo boutonniere's disease. It's where my fingers aren't completely extended, and mainly it's probably because I've broken my fingers so many damn times, right? See how my fingers don't fully extend, right? I can get full extension of my MCPs, but I can't get full extension of my DIP and my PIP. I've got a pseudo boutonniere. But typically, if you see somebody that's got true boutonniere's contracture, their fingers are going to look like that. Really hyperextended MCP, and then flexed other two joints. That's different than a swan neck. A swan neck, instead of having MCP extension, I have MCP flexion, proximal flexion, DIP extension. So I kind of end up like this. I can't even do it because my fingers won't hold that position. I think I got a picture up here. So here's swan neck down here, right? What's my drawer not up? There's swan neck down there. So I get some flexion going on at the MCP, right? And then everything kind of happened. But those are the two main ones you'll get questions on as far as deformities go. I know we have APAN, I know we have Benediction Hand, but it's boutonnieres and swan neck that I would be worried about. So I'm trying to limit it down. So carpal tunnel, dequer veins, your two Colles fractures, and then your swan neck and boutonnieres. If I was focusing on anything of the hand, those are the ones I would memorize. And then everything else, if you get it, you get it. Unfortunately, it's one of the ones you have to kind of rule out.
So for the swan one, the PIP is hyperextended, your DIP is more a little bit flexed.
Mm-hmm.
Okay.
All right, so now let me see if I can get to Diana's question about the special tests. Thought I had a slide on which special tests I would worry about. Let me figure it out here.
Mr. McKeever, I have a quick question.
Yep, good.
Is it bad that I'm not using my the PTA exam book at all? I only use it to review for when I take the tests, but watching the videos and taking notes and studying that's
No, use whatever works for you.
That's okay though?
Yeah, I mean, for me, I read the whole Score Builders book front to back, and that helped me because I'm a visual learner, and that's the way I learn. And I know some people look at that book and go, "There's no way I can read through that. It's going to confuse the hell out of me."
Yeah.
So it just depends upon the. I mean, the videos are great. They don't help me as much as reading does. But if the videos help you, use them.
So
There's not a right or wrong way to study. But the main thing for studying is whatever works for you.
but it's like covering.
It's covering the same stuff.
Okay.
Yeah.
That's what I was just worried about.
Yeah. I mean, if Riley wants to study with a pink card around her neck the whole time she's studying, that's her way of studying, right? It's just everyone studies a little differently.
Okay.
Yeah, actually, Diana. So if I was looking back through, if I am I'm going to say betting person, my tests that I'm going to be worried about in the upper extremity are Adson's and empty can. Those are my primary ones of right? Adson's, empty can, and then Phalen's. I'm going to add Phalen's to that as well, right? Phalen's is for, what's that for? You guys remember?
Phalanx? Double
Phalanx.
L?
What's that?
Oh, PH.
PH, yeah.
Oh, I haven't even. I think I saw that, but I haven't.
Yes.
The thing is that in the videos, they have a workbook, and in the workbook versus the video, there's so much more tests on the. So I wasn't sure. I'm like, I don't.
Yeah, that's why I'm trying to give you the ones the main ones I'd be worried about. I'd be worried about empty can at the shoulder, and then Adson's at the shoulder, right? Empty can is testing for what?
Supraspinatus. So you're
impingement.
Right.
Right. That's it. And most of if you look at most of your shoulder exercises, they're for impingement or shoulder tests. They're almost all for shoulder impingement, bicipital impingement, supraspinatus impingement, whatever it is. Right. So empty can's the major one in the shoulder. And then Adson's is testing for what?
TOS.
TOS. Good. Right. And then Phalen's for carpal tunnel syndrome.
And then Adson is when you are looking at the examiner.
Mm-hmm. Yes, right. At the examiner versus Alan is away.
Look, Alan is looking away. Yeah. Okay.
Yeah, I like the way she did that. Yeah, go ahead, Brooke.
What is the positive for this one again?
What happens? Yeah, what would be positive? Your hands would go numb because you're compressing your carpal tunnel. So your three main fingers, these three fingers would go numb.
Okay.
Because it's a median nerve test.
How long would they hold that for?
30 seconds, I think, is what the hold is for, if I remember correctly. It's not gonna ask that specific about it. Okay. The main thing is what does a positive look like? Well, numbness. And then what is it testing for? Median nerve impingement.
Median nerve impingement. Okay.
Yeah.
Okay. Thank you.
What's positive for empty can? They have what?
One side is weaker or there's more pain.
Yeah, either weakness or pain. For most of the tests, weakness or pain is the answer. Right? I mean, it is. For Adson's, what's a positive?
The radial pulse disappears.
Yeah, pulse disappears. Good. Yeah, you guys got it.
Check. Those are easy. I could do that.
Yep.
Okay. Thank you.
Yeah, so those are my main ones of the upper extremity I'm worried about. Right? And then I get down to the lower extremity. I'm worried about Thomas. What's Thomas test for?
Is that contracture of the hip flexors?
Yes, quad contracture, right? Yeah. That's where I lean back and I pull my knee up and the other knee comes up with it. Right? So Thomas is my major quads. And then, go ahead.
No, sorry. I was just going to say that the Eli one, that one's testing for just tightness, right?
Yes, just tightness.
That's why I like contracture for the other and then tightness for the okay.
And in reality, contracture and tightness, same thing, right? Yeah, don't get totally lost on it. The hamstring length test, what is that testing for? So don't let it be a trick question.
The length of your hamstring.
Yeah, right? That's typically hamstring length, or what's the other term for that test? The 90-90 test, Remember, we did that one. That's where you lay them back, you put their hip at 90 degrees, their knees flex at 90 degrees, and then you have it extend. Do you remember we did that one in class? And that was to see who was tight in the hamstrings. I think I did it with Anthony up on the table, if I remember correctly. Where we extended that up and he couldn't extend his knee at all because his hamstring was that tight.
Would that be passive insufficiency?
Yes. Yes. Yeah. Good.
Nice, Brooke.
I had to
Would
think
you
about
say
that for I had to think about that for a second, but yes, it was.
Would you say the Faber test would be one of them?
Yeah, but the one thing about Faber is that Faber tells you what it is right in its name. So that's the bonus of Faber, right? Flexion, abduction, external rotation. Right. So Faber tells you kind of what it is. That's one of the ones I'm not really worried about because it's in the name, right? Ober is another one. What's the Ober test for?
TFL tightness.
TFL tightness, right? And remember, with Ober test, you're dropping one leg over the other.
And they have to try to adduct, and if they can't.
Well, they don't actually actively try anything. You're letting the leg fall.
Oh, letting it.
Yeah, you're going to let it fall. And if it doesn't fall, then they have tightness of the TFL.
Oh, okay.
Because you're going to lay them down and drop the one leg over the other.
And then there's modified to avoid passive insufficiency.
Yes,
right?
there is modified as well. Yeah, where you bend the knees. That's what you're talking about.
I think you just leave it straight.
Oh, okay. Yeah. Okay. Yep. The straight one. I get those messed up, but they're not going to get that specific. It's going to be what is the Ober test for?
Okay.
Right. So those are the main ones, the upper leg. And then the knee, we have anterior, posterior drawer. Right.
But you want to do the Lockmans, right? Like that's more effective because
it is more
of
effective.
the
Yes.
flexion, right.
Yep. Good. Right. And then the posterior sag is actually a little bit more effective than the posterior drawer test as well. Right. But again, for the most part, it's going to be anterior, posterior drawer. And then you're going to have your medial and lateral drawer test, which tests for varus and valgus stability, right?
The medial and lateral test?
The medial and lateral drawer test, where you're testing, it's a varus and a valgus test, basically. You're putting stress on the medial side and the lateral side of the knee to test for those ligaments.
Would you say also like the McMurray or the medial meniscus?
Yeah, maybe, but that's not one I would be 100% worried about knowing inside and out.
Okay.
I mean, is it going to come up? Maybe, but I'm trying to limit down on your tests a little bit. And I think if you already just went to McMurray's for medial meniscus, you don't have to study any more of that.
Yeah, no, I think I got that one.
Yeah.
Okay.
I just remember what I always remembered is McMurray's was like McDonald's and the meniscus looks like a Big Mac. So that's the way I always remembered it. That's the way I always remember that one. It was my weird remembering. And then the two of the ankle, you have Homans, which is the test for what?
DVT.
DVT. Good. And Thompson's is the test for what? Do you remember Thompson's? Thompson's is the test where you squeeze the gastroc and you should see plantar flexion, right? But if you don't see it, that means there is an Achilles tendon rupture. So that's a test for Achilles tendon ruptures.
Which one did you say the first one was?
Home
For ankle?
Homan's test, I'm sorry. I call it ankle because it's down at the calf, right? That's why I divide them into areas that I need to memorize. So I talk hip, I talk knee, and then I talk lower leg, basically. So Homan's is for DVT tests, where you squeeze the head of the gastroc and see if you cause some pain. And you check for redness and tenderness. Does that help a little bit? But those, if I'm honing down my special test, Diana, those are the ones I'm honing down on. If you have time to review, if you have time to review the others like NEARS and I don't even know what some of the other ones are, but stuff like that, great. But if I'm honing down, those are the ones I want to know inside and out.
Yeah, with the NEARS and the Hawkins, I pretty much know those, but I feel like I definitely wanted to narrow it down, so this works for me. Thank you.
Yeah, those are the ones I've been honing it down for. And again, you get the NEARS and Kennedy Hawkins, they're for impingement again. right? Bicipital tenosynovitis test. It's the test for bicipital tenosynovitis. Like it says it in the name.
So,
I was also thinking like, oh, sorry, bro.
no, go ahead.
I was also thinking, just because I'm trying to like get down a lot of stuff for the shoulder, I was also thinking like, what do you think about the flap lesions? Because I feel like I've gotten questions about the flap tears.
Okay.
And so I know like flap 2 is like the most common, flap 4 is like the least common. 1
Wow.
and 3, I believe the tendon's still attached.
You're way farther than I think they're going to ask questions on.
Okay,
That's,
great.
That's diagnosis.
Yeah.
The main thing they're
Well, I
looking
don't-
for is if it says slap, what is torn?
Superior labrum.
Superior labrum, anterior to posterior,
That's all I have to know.
right? And then knowing the difference between a slap and a banker.
Okay.
Those are what you got to kind of review.
Okay.
So like, you think they'll ask questions like for the near test? I know it's the supraspinatus and I think the biceps tendon. It's not going to be that specific.
No, it's mainly going to be asking what you're testing for. You're testing for impingement. And what does a positive test look like? Pain, owie.
Yeah.
That's what they're going to be asking for the most part. And again, or they may ask, where is the impingement likely to happen? And for the most part, all of your impingements happen where? In the shoulder.
Subacromial space.
Subacromial space. Yeah. Yeah. If you know that, then you've got most of your tests of the shoulder.
Okay, that brings up another thing. I had a question about the glenohumeral rhythm. So it is 30 to 60 is the first for the glenohumeral, right?
Okay.
I'm sorry,
I'm trying to see what you're saying, and then I'll correct. Go ahead, say what you're going to say, and then we can correct it.
the glenoid fossa, right?
Okay.
And then they said it's like a 2-to-1 ratio,
Okay.
but and then it goes, hang on. The rest is scapulothoracic, but then the glenohumeral makes up 120. That's where my brain is with that. I can't.
Okay. Let's try to make this a little easier, right? Give me a second here, because I thought I had a picture of this one. Give me 1 second. No, we're not talking about lung butter right now. Lung butter. I have too many pictures. Not amputations. Sorry, I got to go through my whole. I guess I don't have, I thought I had a picture, but I don't. Okay. So we'll just go. There it is. Aha. I knew I had something somewhere because I'm a hoarder. All right. So the shoulder, scapulohumeral rhythm, right? The first 30 degrees of scapulohumeral motion. So the first 30 degrees of my shoulder flexion or abduction, doesn't matter which one it is, right? Both of them are the same. The first 30 degrees is pure glenohumeral motion. So it's pure humerus moving on the glenoid fossa. After that, for every 2 degrees, my humerus moves upward or downward if we're going downward rotation. For every 2 degrees that moves, my scapula has to rotate 1 degree. Because if it doesn't rotate, so if I take and I lock out my scapula so it can't rotate, I can only get about 30 degrees of motion. It's banging against the top of my subacromial space. So that means my scapula, so as my humerus is moving up, my scapula has to move with it to allow it to move. They are not going to ask you and be mean like I was where I asked you math questions, where they'll say, the patient has 120 degrees of motion. How much of that is pure scap? No, they're not going to make you do math questions. Okay. But they may say something, it's probably going to be, it'll be an easy question. So it'd be like the patient has 60 degrees of shoulder flexion. This is the extent of the math that you'd have to do. The patient has 60 degrees of shoulder flexion. They're limited to that. how much upward rotation is the scapula doing? So I'm limited to 60 degrees. That means I can't get to 90, right? So I'm here. That means I eliminate my first 30 degrees because 30 degrees is just the humerus moving. Does that make sense so far? Right? So that means I'm down to only 30 degrees of motion because 60 minus 30 is 30. That means my scapula has to move half as much as my humerus does because it's a 1-to-2 ratio. So how much upward rotation will my scapula do? If it's half as much as the pure motion. So if I move 30 degrees, 15 degrees. You see how that question worked out? Let's give a harder one just so that we can kind of work through it again. So your patient is, let me get my color pen up here. Your patient has 120 degrees of shoulder, right, thank you, abduction. Right, so I have 120 degrees shoulder abduction. How much, oh my God, I can't write today. Scat motion. So how much scat motion is occurring? So what's the first thing we have to do?
I would take off the 30 because.
Good. We're gonna take off the 30.
Okay.
So how much motion does that leave us with? 30 minus 120 is, come on, that's pretty easy.
Oh, you're asking me?
Yeah, it's fine.
Oh my gosh, I'm horrible with quick math. Wait. Is that 90?
90, there you go, good, right? And again, I'm picking a larger number. They're not, again, if they're gonna ask you questions, it's gonna be like 60 degrees or I don't know, 40.
Mm-hmm.
It's not gonna be huge numbers. I picked a bigger number to make it more difficult on purpose, okay? Yeah, so we have 90 degrees. So that means my first 30 doesn't count. My next 90 is what we're worried about. Does that make sense?
Mm-hmm.
And we know that my scapula moves half as much. There you go, Riley, right? My scapula moves half as much. Quiet, Riley. Moves half as much as my humerus does. So half of 90 is?
45.
45, yeah. Does that make that easy enough for you? They're not going to do the reverse. They're not going to make you calculate downward rotation. That would be mean.
Yeah.
But it would be the same, right? It'd just be in reverse.
Okay.
Does that clarify that a little bit?
Yeah.
Yeah. It's so for the first, you eliminate the first 30 degrees and then calculate it from there.
Okay.
And again, the most time what they're going to ask you is what is the scapulohumeral rhythm? And the scapulohumeral rhythm is first 30 degrees, pure shoulder motion, from then on 2-to-1 ratio.
Okay.
Or 1-to-2, depending upon how it's written, right? If it's talking about scap versus humerus or humerus versus scap. Does that help?
Mm-hmm.
Cool. Okay. That's not that bad. That's an easy one.
For the joint, the open and closed pack positions, I'm gonna narrow it down to shoulder, knee, hip. That's fine.
Yep. That would be the ones I narrow it down to.
And what
And
about
elbow.
the spine?
Elbow.
Okay. Okay.
Again, spine, for the most part, you can calculate what is open and closed packed, right? Spine, a
Right,
little bit of
max-
flexion,
max-
right?
Max extension for closed.
Yep, exactly. Yeah.
Okay, so you said elbow.
So the same thing
shoulder.
we just remembered about the, what do you call it, convex concave rule. Elbow,
Okay.
shoulder, hip, knee,
Okay.
and maybe ankle if I'm feeling exciting,
Mm-hmm.
right? You're not going to have to necessarily know. I mean, when I get down here to the wrist, it kind of makes sense. If I'm full extension or full flexion, I'm closed packed,
Right.
right? So it's somewhere between that I'm open packed. So for the most part, honestly, when I was doing open and closed pack positions and I was confused on it, I just put myself in the positions. Like I was okay, well, if I'm locked out on my elbow, I'm definitely closed packed, right?
Right. Yes, I've been memorizing, like, I know like the hip and shoulder. So I just memorize the numbers, right?
Yeah, yeah, sure. I don't even know if I'd go as far as memorizing the numbers, because pretty much if you understand where open packed is, the numbers will solve themselves.
Okay. Oh,
Right? They're not going to be, it's not going to be like, is 15 degrees of shoulder abduction open packed or is 25 degrees? It's going to be a clear difference. You know, be like 120 degrees of shoulder flexion versus 90 or something like that, right?
okay.
I keep banging my camera and it bouncing. This is actually a really good session. See, it's nice to have a small group where Anthony's not interrupting us. I mean, sorry, Anthony. Anything else? Does that help you guys a little bit? Because you guys are going into neuro now, right? And this is where I'm going to cry on Tuesday, I'm pretty sure. Because this is my section and I'm going to be like, no, you guys learned nothing. No, I'm just kidding.
I like the neuro the most.
I know.
I feel
Well,
like
so-
I enjoy musculoskeletal more than anything else.
Well, I think I enjoy neuro just because it's
I hate
challenging.
neuro.
I enjoy neuro
That's why I
because it's
don't like
challenging.
I like
Um,
neuro because it clicks more.
and that's what we get. So what I find is people, musculoskeletal clicks for certain people and neuro clicks for other people. And
Yeah.
it's just, that's just the way it is.
Oh.
The one thing I'll say, because I just ordered our results from January and April. And the weakest parts that we had as a program were pathophysiology and musculoskeletal. Those are the two weakest areas that we had. Now, what I noticed was there was nothing that was like drastically weak. It's not like musculoskeletal was a 500. Everything was still in the like close to 600 range. It's just musculoskeletal and patho were lower than the rest of the stuff. So that's why I'm going to plan as we get closer. We're going to do a just patho review day,
Mhm.
where we just kind of go over the major pathos that are out there that you have to go. That's why we're also going to have a pharmacology review day where we just go. But I want to make both of those a little closer to the test, because that way those stick with you right before the test kind of idea. Because if I give you or pharmacology right now, by the time you get to the test, you'll forget what a statin is. So a little closer probably will stick in your head a little bit closer. So I did kind of review the stuff. I do want to give you guys at least an exciting piece. Everyone that is licensed has been placed right now. So, and I don't know if you guys looked at the job posting board, but I had like 9 jobs in the past week.
I'm actually teching right now for the rotation that I did on my last one.
Awesome.
And they told me that if I get my license, they'll hire me. So
Stop.
I'll get my license. And
When I get my license, I'll have a job.
Yeah.
Thank you. Not if.
Yeah.
Right.
But they are hiring a lot of PTAs everywhere.
Yeah. Well, it's because we're starting to get, what do you call it? Elective surgeries back.
Mhm.
Right. Yeah, I don't think they hired some. I'm wondering, honestly, Riley, I'm wondering if that was just a restaffing position to bring somebody back.
I think they made a mistake because I went to their website and there was nothing for physical therapists. It was only for physical therapist assistants. It was only for physical therapists.
Well, it could have also, like I said, Select the other week, I called Joel, Mr. Gersh, because they posted like 10 positions. And I'm like, wow, you're hiring a lot of PTAs. And he's like, well, 2 of those are open. The rest of them, they were bringing back their PTAs that they had laid off. Right. So that may have been the other thing with Sunrise. It may have been that they had to, because like at PIMA right now, if I take, if I take the program director position, they can't fill my position until they post it. Or if they brought me back to that position, they have to repost my position and then rehire me for that position and pull me out of the program director position. So it's weird the way corporate sometimes works. And let me tell you, I'm really enjoying being program director.
Mr. McKeever, I have a quick question too.
Yeah.
Tell me if I'm doing too much with this. On the workbook, they have all the muscles that do like shoulder movement, elbow movement. I've been making like flashcards. I haven't dived deep, but do you think it's a plus or should I not worry about that?
For me, the main thing I'm going to say about as far as movements now is if you're studying your origins, insertions, actions, and innervations, that should pretty much answer those questions for you.
And nerve.
And nerve roots, yeah.
Right. Okay.
when I say nerves, I just include nerve roots. And because of you guys, I changed the way we're doing bio, just to let you guys know. Because I noticed that when we got to third and fourth semester, some of those muscles had fallen away.
Oh,
And what's that?
absolutely.
And so what I changed bio to be now is the first semester is just bones. So the bone landmarks, blah, blah. And then we're doing blood vessels and brain segments for the second practical. And then in second semester, we're going to do the practicals. The first practical is going to be upper extremity, origins, insertions, actions, nerves, and nerve roots. And then the second practical is going to be lower extremity the whole way through again. And that's more in alignment for what the APTA says is the right way to do it. I think we've clung to the other way because that was the original anatomy instructor's way of doing things. And I finally have some say over it. So I'm like, nope, we're changing it. And it seems to be going well. The new group of students is absolutely paranoid. They are just already freaking complete. We started going through the bones and they got to the foramens of the skull and all that fun stuff. And I said, oh, just wait, sweeties, it's coming.
I think my regret from like school, when I think about it, and I'm gonna be just totally honest, I think I got it more like I studied it to pass the test, but I didn't like ingrain it in my head like forever. You know, I was just kind of worried of the program's fast itself. And so I think I was just trying to pass the test. That I on some of the stuff I feel like I just kind of slid through, you know, and so, now it's gonna bite me in the ass.
Oh, and so one of the things I found out is when I went on back when I was in school, when I went on vacation, I took vacation between semesters. I know, right? I back when I could take vacations. I went to Jamaica. Because, by the way, if you can get to go to Jamaica, go to Jamaica. It's beautiful. Everything's ivory them on. But I went there and there was a girl that I noticed she was walking around with this book and I'm like, oh my God, it's the anatomy textbook. And so being the nerd I asked her, I said, so what? She's like, well, I'm studying for my physiology test in Canada. And she goes, and these muscles and nerves are not sticking with me. And one of the things I told her was when I just studied my flashcards, it didn't stick. What I had to do is study my flashcards and then do the movement, study the flashcards and then do the movement, study the flashcards, do the movement. And then it stuck. So when I'm working on my external rotation, I'm sitting there doing the movement that's on the card, and then it stuck for me. I took her down to the gym one day and we went through all of her muscles that she didn't know. And she's like, oh my God, why didn't they do this with me in school? And I'm like, oh, I should be a teacher or something. So don't skip out on doing the movement as well when you're studying it, Diane, is what I'm saying, because that'll help ingrain it, right? If I'm going, okay, my biceps origin is this, my insertion is this, my action is this, right? Then it helps me kind of get the idea.
Yeah, no, that's right.
But yeah, so I mean, I just to let you guys know, once you guys get your licenses, there are jobs out there for you. That's one of the things I want to say is, and you know, I've seen, the other thing is hopefully I should have information on the 2,000 hours being passed shortly, which means theoretically you could go into home health if you wanted right off the bat, if you wanted. And there's a couple of home health agencies that are starting to hire now as well. They've been holding off a little bit on PTAs because they just haven't had the evals. And so the PTs have had to do treatments, which I don't know if the PTs like or not. I can never tell that. I think some of them really like doing treatments and some of them are annoyed when they have to do treatments. I'm like, that's a PTA job, like folding the towels. Any other questions?
I have a quick question. It's just about like a skilled nursing facility is opening up like right down the street from me. Like they're just building it.
Yep.
How would I figure out if like they're hiring and stuff?
Well, I mean, once it's fully built, just go down and ask if you can shadow in the PT department.
Okay.
Like tell them I'm working on getting my license right. Here's the thing. If you get your face in front of them.
Yeah.
Right.
It started building when we started school and now it's like almost finished up.
Yeah.
So I was like, and it's 3 minutes from my house.
I mean, that's how I got into my pediatrics is that I worked at the hospital that I was working at. And then I went and I volunteered at the pediatrics clinic for free for like 3 and 4 months. And yeah, did it cost me extra time? Absolutely, it did. But it got my face in front of them. And then when a job opened, I was like, look at all this I did for you.
Yeah.
Right. And so I was more likely, like they're more likely to hire, like just why, same reason why clinical placements usually hire you,
Yeah.
because they've already kind of trained you and kind of gone through it. Why wouldn't they? That you don't have to go through orientation. You don't have to, you can hit the ground running.
True. Yeah.
Right. I think what's her name? Bianca, I think got hired by one of her clinical placements, if I remember correctly.
Yeah. I did mine at that one too. And they were like, come back. And then my last one I was at, they were like, come back.
And you're like, no, okay. No, just kidding.
Well, no, I really, they were really good. And I just really liked everybody there. And it's a consideration. I kind of want to do like per diem.
Yep. And the funny thing, I had the exact opposite. My last clinical rotation was like, never come here again. I'm not even joking.
What?
I don't know if you guys know, but I almost failed my final clinical rotation. And the whole reason was because there was a competition. I didn't realize that my CI graduated from the competing school that Penn State competed with in town. And she didn't like Penn State, so she purposely was failing me. My clinical director had to come in and like I had to do all these special assignments to pass my final clinical rotation because she failed me. She said I didn't know anything. And I'm like, well, you're not letting me, like literally, I didn't get to touch patient. Our clinical rotations were 6 months. I didn't get to touch patient until 3 months into it. And that was my final clinical rotation. By then I felt like I knew what I was doing and I couldn't touch patient.
Wow.
So sometimes it's a good experience. Sometimes it's not so good. For the most part, ours have all been good.
Mm-hmm.
I know Dr. Vreskin, that's what she's been doing for the past 3 days is working on the other groups they have their their first long clinical. And so they're all getting excited. They're in neuro with me right now and they're freaking out too, because we just went through like a lot of the neuro and like, this is a lot of stuff. Yeah. I will say I miss you guys. You guys are a good group. So it's challenging when you have to change the way you teach, because sometimes each cohort's a little different. And so you have to modify the way you teach with every cohort. And so the new group the brand new group we got is the first one they're a little different than everyone I've ever had. They're it's not in a bad way either. They're just not as motivated.
Mm.
There seems to be a little bit of a motivation problem, and it's not bad. It just seems like no one's ever forced them to be motivated type idea. And they took their first test, like even in communications, and they didn't do well on them for lay and lie. And so they're like, oh, I guess we got to study. All right. I think what I'm going to do is I'm going to save the Quizlet for on Friday when we have more people. I'll just increase the length of it. I'll add neuro to it. So we'll have a longer one because there's no sense in doing a Quizlet with only 3 of you guys. I'll post a link to it if you want to go back and review it already. But I think we'll save it for Friday when we have a little bit more people, and we'll just do it on a Friday with everyone being here. And again, I apologize about being sick. I'm sitting here, my stomach is just not doing well. So just don't, I guess the rule of thumb is don't eat bad peanut butter. I didn't know peanut butter could have salmonella. Yeah, I'll be better. I just got to work it out. I got to fluids and flush. That's basically what I'm doing. So are there any other questions about ortho? You okay? All right, get to studying your neuro, and I will see you guys on Tuesday at her meeting. So get out of here.
Can I stay after?
Yes.
After?
You may
Okay.
say whatever you need. I'm going to stop recording though, if you don't mind.